Hello and welcome back to What the Health. I'm Julie Rovner, Chief Washington Correspondent for KFF Health News, and I'm joined by some of the best and smartest health reporters in Washington. We're taping this week on Thursday, October 16th at 10 a.m. As always, news happens fast and things might have changed by the time you hear this. So here we go. Today we are joined via video conference by Lauren Weber, The Washington Post.
Hello.
Anna Edney of Bloomberg News.
Hi.
And Joanne Kenen of the Johns Hopkins Bloomberg School of Public Health and Politico magazine.
Hi, everybody.
Later in this episode, we'll play my interview with health insurance expert Louise Norris, who will explain some of the changes coming with this year's open enrollment for Medicare, which began Wednesday. But first, this week's news. So today is day 16 of the government shutdown, and there is still no discernible end in sight. This week, Republicans shifted their main talking point against Democrats. They were arguing that Democrats are trying to restore eligibility for Medicaid to illegal immigrants. Now it's become a general takedown of the Affordable Care Act and arguing that in urging continuing the expanded tax credits for ACA premiums, Democrats want to throw good money after bad because the ACA has made health care more expensive. First off, it has not. There's lots of evidence that the ACA has actually held down health spending increases, although other factors have pushed it up. But more to the point, do Republicans still not get that the expiration of these additional tax credits are going to hurt their voters more than it's going to hurt Democratic voters? I see arched eyebrows.
It doesn't seem like they get that yet, but I'm not in the strategy room, so a little tough to say in what their line will be with this game of chicken. They basically are allowing firings of federal workers to continue to go forward in a way that they hope maybe will turn the tide and attention. It doesn't seem to be working. So, I don't know if they're having these conversations quite yet, but I know that the notices are starting to go out to some people in some states about these increases. And so it really might depend on what that backlash is from people who are going to see much higher costs for their health care.
Yeah, apparently open enrollment began in Idaho on Wednesday. I didn't realize that it started early. And so there's just that one little state where people are actually able to see what these premium increases look like, assuming that they do not continue these extra subsidies. I'm wondering sort of about the Republican strategy of, we couldn't get any traction with the illegal immigrants, so we're just going to move to the ACA is terrible. Joanne.
Well, we talked about this a couple of weeks ago and Julie linked to the story, and I wrote about the politics of this. And one of the issues is Trump is a master of deflection. Are these people going to think it's really Republican policy, or are they going to think it's greedy insurers, leftovers of, the flaws of Obamacare itself, it's Biden's fault, and also concentration. Where the voters are in these states, are there enough of them who actually are going to turn out to make a difference? They're not going to flip Texas, right? Are there enough of them in swing states or closer margin states to make any difference? Are there enough in a single congressional district to make any difference? Part of it, I think they're just sort of banking on that they won't get the blame, that it's really easy for us to get mad at our insurers. I think that's part of what they're hoping, that they can just say, blame them, blame the structure of Obamacare. It's not our fault. So whether that works as a selling tactic remains to be seen. If they thought it was a huge political risk, they wouldn't do it.
True. Lauren.
I've been fascinated to see Marjorie Taylor Greene come out and say, wow, these are some expensive premiums. And her seeming split from some parts of the Republican Party is fascinating to watch for many reasons. But it's just a lot of money that these people could be staring down. There was an analyst quoted in some coverage that was like, people will have to decide between, groceries and rent. If you are paying over $1,000 more a month for some of these folks, that is a significant amount of cash. So I do feel like people vote with their pocketbooks more than they vote with anything else. But to Joanne's point, will they attribute the blame? I'm not sure.
So Politico is reporting on some possible options for a deal on those subsidies, which lawmakers are apparently talking about quietly behind closed doors since actual negotiations are not yet happening. Two of those possibilities seem like real potential common ground, minimum premiums, so people who are now not paying any premiums. And the argument from some Republicans is that, that's pushing fraud because some people, if they're not paying premiums, don't even know that they're enrolled and that the brokers are, making money, which my colleague Julie Appleby has written about ad nauseum. So that seems like a possible place for compromise to have, a minimum $5 a month premium so people would know that they have insurance. And maximum incomes for the subsidies. I know that people are floating like $200,000 a year or something like that. Then there are two possibilities that at least strike me as less likely. One of them is grandfathering the subsidies, so only people who are getting them now could continue to get them, which would be problematic at a time when the economy seems to be shedding jobs, and changing the abortion language, which I don't even want to start with. So is that I'm seeing the first two as a real possibility, the second two not so much. I'm wondering what you guys think.
I mean, I've talked to some Republicans who claim that the current structure of the subsidies would enable families who are making $600,000, which all of us would agree is a fair amount of money. When I was told that, I went on a whole bunch of different calculators and pretended I was making $600,000 and could I actually get the subsidies? And I kept being laughed at by these calculators. I think there are probably some cases where this has happened. It's a complicated formula with 8% of your, we don't have to get into the technicality. There may be.
But it is a percent of your income. You only get a subsidy if it's more than.
And you'd have to have a premium that's like an extraordinarily rich premium. I mean, it has to be in a really, 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 really high number. Can this exist? Under current law, several reputable Republicans have told me yes, or conservatives, they're not all necessarily Republicans, conservative on this issue at least, have said yes. I mean, if that's the kind of thing that, you want to set an income cap that was probably what was intended, I would take that out of the non-starter and into the starter pile. I don't think that's enough, but I think that's a reasonable discussion for both sides to have. I don't think the intention was to subsidize people who are really not lower middle class.
The people who got the big tax cuts.
Right. They're getting other tax cuts. I thought that was an interesting piece with some interesting options, but I'm also hearing escalating rhetoric, back to 2014 kind of rhetoric, back to repeal kind of rhetoric. Everything that you hate about the healthcare system is the fault of Obamacare. Nothing in Obamacare works. We've got to they're not saying repeal, but they're saying reform it. And I'm hearing more and more of that. Like it's just in the air now. So, and John Cohen had a really good piece in the Bulwark about some of the background of this. I think it could mean that this becomes a more intense tug of war, that it does not bode well for a quick resolution of the shutdown. I don't think we necessarily get into a year-long repeal fight, even if you call it reform. But I think that these demands and this rhetoric about, high-risk pools worked. Well, no, they didn't. That this is why your insurance costs have gone up. No, there's a whole bunch of incentives and structures and bad stuff in our healthcare system. Obamacare fixed certain problems. Those of us, we all have employer insurance, I believe, and all of us face cost increases and frustrations and hitting our head against brick walls and delays and things are not perfect by any means, but it's not because of these subsidies in Obamacare.
And it's not because of Obamacare. Obama himself this week was on a podcast and said it was intended as a start, not as the be-all, end-all. I was surprised. I mean, I think one of the reasons that Republicans, this is now in their talking points about we're going to go after, Obamacare, and Mike Johnson, the speaker, had kind of a rant on Monday, which sort of opened this up. And I think some of the Republicans were also talking about it on the Sunday shows. But I can't imagine that Republicans don't remember that the last time they had this big fight against Obamacare won. That was in 2017. And if anything, it's even more popular now because there's twice as many people on it, which was kind of the way I set up my first question.
Right. But the dynamic of a year's worth of repeal votes while other things are actually functioning in government versus a fight about this when Trump holds a lot of the cards in a shutdown. It's comparable, but not the same. Anna?
Well, and I also have to wonder if an actual extended replace or reform, whatever we're going to call it, fight is what they want, or if this is a strategy to help blame the increases in premiums that are coming on Obamacare in general, directed towards the Democrats, right? You can see how that line could be drawn. And so if they just keep bashing Obamacare, it's Obamacare's fault that Obamacare's premiums got higher, not because they didn't vote on extending the subsidies.
And we're also talking about Obamacare again. We had been talking about the Affordable Care Act. It had gone from Obamacare, which is politically toxic, to Affordable Care Act, which was sort of a subtle acknowledgement that it had bipartisan popularity among people getting benefits. And now we're back to Obamacare, which sort of tells me, yes, we're back into this endless loop of political fights about Obamacare.
Yeah.
And trying to get to the Guinness Book of World Records for repeal votes on a single piece of legislation.
Well, meanwhile, and I said this last week, and I think the week before, that even if there is a deal on the tax credits, the bigger problem for Democrats right now is that if they make a deal on spending levels for fiscal 2026, which is what this fight is actually over, the administration can simply undo it, and Congress can ratify that undoing with a simple majority of just Republican votes. This week, even Republican Lisa Murkowski wondered aloud why Democrats would do a deal like that. So I'm still wondering how they get out of that box, even if they were to get some kind of a compromise on the ACA subsidies. I certainly don't know how Democrats get out of that box. I think the Republicans don't know how they get out of that box.
They don't realize they're both in the box. That's one of the problems. This is a large box.
It's Schrödinger's shutdown. We will have to see how that plays itself out. In the meantime, I'm not holding my breath. Well, moving on, despite laws against it, as Anna already mentioned, the Trump administration began firing federal workers last week, and the cuts hit particularly hard at the Department of Health and Human Services and agencies like the Centers for Disease Control and Prevention and the Substance Abuse and Mental Health Services Administration. The cuts appeared both sweeping and devastating, at least at first, including the entire staff of the CDC's news journal and lead public health source of information, the Morbidity and Mortality Weekly Report, though by the end of the weekend, many of the firings had been rescinded. It's not clear whether that really was a coding mistake, as was the official explanation, or an effort to continue to put federal workers, quote, air quotes here, in trauma, as OMB Director Russell Vought famously promised before he took office for the second time. Whichever, it's not really the way to get the best work out of your workforce, right? Telling you you're fired. No, you're not. Maybe you are. Go ahead, Lauren.
I would like to go back to a story I wrote in April when a bunch of fired health workers were told to contact an employee who had died. I don't think, based on, the coding error or some of these past things, it does not seem like these layoffs are being done in any sort of organized way. It doesn't seem like they have up-to-date records. It seems like also, are these layoffs even legal based on some of the litigation that's been filed? I think there's going to be a lot that has to shake out there. But I mean, to be quite honest, it is very striking to see a bunch of CDC employees continue to get laid off after. Again, this is an agency that got shot at with hundreds of bullets. Police officer.
Yeah, literally shot
at with hundreds of bullets, and a police officer died responding to that due to a shooter who had been radicalized in part, it seems, from his father's account by information that was wrong about the COVID vaccine. So, to see more of those employees get laid off, I mean, you just have to wonder who's going to want to work at these places. The morale is just completely, as we understand it, terrible. But yeah, I also question if that was a coding error or what exactly was happening there, because there were a lot of priorities of folks that were seemingly let go that are allegedly Make America Healthy Again priorities. But that's also been true for many months of policymaking. So
yeah, there's a lot of right hand not seemingly knowing what left hand is doing in all of this, which may be the goal. I mean, I think you put your finger on it. It's like who would want to work at these places after what's being done? And I think that's the whole idea of the Russell Vought strategy of let's shrink the federal government to a point where it's so small that you can just sort of put it in a box and put it under the bed. That's essentially where we are. Well, Lauren, as you mentioned, Wednesday afternoon, a federal district court judge ordered the administration to pause the firings. But will they actually obey that? And do we even know what offices have been most affected at this point? I mean, we heard a lot of things like the entire Office of Population Affairs at HHS, which runs Title X, has apparently been reduced to one person. The people who do a lot of the statistics and survey work at CDC, all these people sort of appear to have been laid off, but we're not quite sure, and we're not quite sure what's going to happen from here.
I'm not sure if they know they've been laid off and rehired, because if you were laid off, you lost your access to your work email. And then if you get an email in your work email saying, oops, you're hired, I mean, I guess people sort of may just see if they have access again. But I'm not really sure how the actual notification of this somewhat chaotic layoff, no layoff thing is.
It has been chaotic. I think that's a good word to describe all of this. Well, one reason it was relatively easy for the administration to go after the CDC is that it doesn't have a leader or even a nominated leader at the moment after the firing of Susan Menares in August, less than a month after her Senate confirmation vote. Another high HHS position that remains vacant is that of Surgeon General, although that office at least has a nominee, Casey Means. She's the sister of RFK Jr. top aide and MAHA associate Callie Means, and more than a little bit controversial. Lauren, you did a deep dive this week into the prospective Surgeon General. What'd you find?
Yeah, my colleague Rachel Rubin and I did a deep dive into her background. And she's a fascinating example, really, of MAHA today. And you could argue she really wrote the manifesto to MAHA with her book, Good Energy, that she authored with her brother, Callie Means. But basically, she's a very accomplished person in the sense that she went to Stanford undergrad. She graduated from Stanford Med School. She had a very prestigious residency in ear, nose, and throat surgery. And then she resigned. She left and decided she wanted to take a different path and has become a best-selling author, a health products entrepreneur, and has also worked, as her financial disclosures have revealed, to promote a variety of products in some of her work. Financial disclosures revealed that she had received over $500,000 over basically the last year and a half, promoting a variety of different supplements, teas, elixirs, diagnostic products, and so on. And several of the medical and scientific experts I spoke to said that they worried that she spoke in too absolute terms about health. And they were really concerned that as someone who would be the Surgeon General, that she would use that bully pulpit and speak in terms not necessarily grounded in evidence. They pointed to some of her remarks about how cancer and Alzheimer's and fertility was within one's power to prevent and reverse. And they felt like that language went a step too far. And looking at her history, they are concerned about what that could mean for the health of the nation if she is directing it.
She doesn't even have a confirmation hearing scheduled yet, does she? Well, the Senate's in, so they could.
She is pregnant, so I think that is playing into the timing of some of her stuff. But yeah, she does not have it scheduled. Her forms seemingly were pretty delayed, and then obviously there's other things going on. I mean, I think the CDC firing also sucked a lot of health air out of the room of what people want to deal with and spend their political capital on, I suspect. But yes, we shall see.
Yeah, she has to go before the Health Committee, which is Senator Cassidy is the chair. He is not a happy camper at the moment from his public statements, and we do not know what the private conversations he is having at this point in time.
And of course, that committee will also have to pass on the new CDC nominee when there is one.
Yes. And, the last CDC hearing, which all of us watched, I think, he's clearly concerned and displeased by lots of things going on at the federal health agencies. So none of us are in those rooms, but they're probably interesting conversations.
As I like to say, we will watch that space. Well, turning to reproductive health, the New York Times has a story this week about something that we've talked about before on the podcast, arguments by anti-abortion activists that abortion pill residue in wastewater might be contaminating the nation's waterways. Notwithstanding that there is no evidence of that, the Environmental Protection Administration, acting on a request from anti-abortion lawmakers in Congress, ordered scientists to see if they could develop methods to detect the drug in wastewater. Now, the groups that originally pushed this say they were concerned about pollution, but if such a detection method is successfully developed, abortion rights supporters worry that it could be used to trace users, in particular buildings, in order to enforce abortion bans. This is basically another step in this sort of let's try and shut down abortion nationwide. Is it not? Nan, I see you nodding.
Well, I mean, that was my feeling when I read this really good piece that you're talking about. And it's a little bit lower down in the piece when they do start talking about like using this to target maybe buildings or places where someone might have used an abortion drug. And I kind of was like, yes, this is what I assumed they were trying to do as I read this. And the reason for that is not just because like I feel like there's always a vindictive motive or something, but it's because there are lots of drugs that are in our wastewater. And, people are taking far larger amounts daily of many more things that is all going into our wastewater. So particularly why you would want to track that one, which is not used by millions of people for a chronic condition on a daily basis. It seems like there would be an ulterior motive.
And has not been shown to do any harm, even if it is showing up in trace amounts in the wastewater. Although presumably that's what the EPA scientists were also tasked with trying to figure out.
I mean, it's really hard to get rid of a drug you no longer take. I mean, pharmacies don't want to take it back. In my neighborhood, there is a pharmacy at a supermarket that does have a take back, which is great, but it's always broken. If you have any drug that you want to get rid of responsibly and not have it end up, Anna's right. I mean, there's just a lot of stuff in our water. It's really hard to do, and this is not the only drug that is an issue with.
Although, if you Google it, there are a lot of places where you can actually take back drugs.
It's hard. It's limited hours, limited access. The machines are often... I've been trying for a couple of them for a few months, actually.
You do have to actually take some steps actively to do it. Well, turning to drugs and drug prices, there was so much other news you might have missed this, but President Trump last Friday afternoon announced a deal with a second drug company to bring back manufacturing in order to avoid tariffs. This deals with AstraZeneca, which promised to build a plant in Virginia. But Anna, is there any promise to actually bring down prices for consumers in any of this?
Minimally, possibly. It's a lot like the Pfizer deal, and we saw, that focus largely on Medicaid that already has extremely steep discounts that are required by law. And so how much they'd actually be slashing to offer the most favored nations pricing that Trump wants to the Medicaid program, it seems like that probably isn't a huge leap. And certainly we saw that Wall Street didn't react with any hair on fire. They're not worried about the bottom lines of these companies when these deals come out, and they're avoiding tariffs for 3 years. So kind of net positive, seemingly. We don't have all the details of the deal.
Like with the Pfizer deal where we never got all the details.
Yeah, exactly. So there's some stuff that we still don't know, but Medicaid is the main focus. And then they'll offer, again, some of their drugs on Trump RX. So, maybe if your insurance doesn't cover something, or if you don't have insurance and you want to get a drug, that might be helpful. But, most people, I think, are going to opt to pay their lower copay than the cost of a drug that is discounted, but still full price.
Well, in case you're looking for a reason why it might be a good thing to reshore some drug manufacturing, the World Health Organization this week warned of potentially poisonous cough syrup made in India. According to one of your Bloomberg colleagues, Anna, 22 children have died in the central Indian state of Madhya Pradesh. I hope I'm pronouncing that close to right. And this is far from the first time poisonous substances have been found in medications made in India, right? You've done a lot of reporting on this.
Yeah, for sure. And these are really tragic stories that now seem to keep, particularly with these kind of cough medicines, keep popping up. And thankfully, the FDA did put out a message saying these cough medicines in this round were not sold in the U.S., but there have been times where India has imported some of these. There were children in the Gambia that died last time. This was a few years ago, because what's happening is some of the drug makers in India are supposed to be purchasing a solvent. It's propylene glycol. Well, that solvent that helps the medicine kind of all mix together, it can be a lot cheaper if you buy something that looks like it, but it's actually deadly, diethylene glycol. And so that's what some of these companies are doing, is saving money and substituting a deadly ingredient. And so we see that this is a problem a lot of times with some of the drug makers. And it's happened, unfortunately, particularly in India, where the cost cutting, the corner cutting has actually affected people's lives. And in this case, tragically, children.
Yeah. There is reason to kind of want to keep drug manufacturing where the FDA can keep an eye on it, which I know you will continue to report on, because that has been your specialty, I know, of late. All right, that is this week's news. Now we will play my Medicare open enrollment interview with Louise Norris, and then we'll come back with our extra credits. I am so pleased to welcome to the podcast Louise Norris. She's a health policy analyst at MedicareResources.org and at healthinsurance.org, and the author of some of the most helpful guides to health insurance out there, and the person who keeps track of all the changes for health reporters like me. Louise, so happy to welcome you to What the Health.
Thank you so much, Julie. It's a pleasure to be here.
So we've talked a lot these past few months about how the Affordable Care Act and its potentially skyrocketing premiums for 2026 is about to happen. But we haven't talked as much about some of the changes to Medicare, for which open enrollment began this week. Now, most years it's probably okay for Medicare recipients just to let whatever coverage they have kind of roll over, but that's not the case this year, right?
Well, I feel like it's never the best idea to just let your coverage roll over because there's always plan-specific changes that people just really need to pay attention to. And even though averages might be fairly steady in terms of premiums and benefits, that doesn't mean your plan will have a steady premium or benefits. And for 2026, we're seeing, like in the Medicare Advantage and Part D, standalone Part D drug plans, there are fewer plans available on average and actually a slight average decrease in premiums. But I feel like if people see that as the headline, they might be sort of lulled into complacency of like, oh, I just don't need to look, when in reality, there's quite a bit of variation from one plan to another. So although the average standalone Part D plan premium is actually decreasing slightly, some plans are increasing their premiums by as much as $50 a month. So you need to really pay attention to the notice you got from your plan about what's happening for 2026 and then comparison shop. Comparison shop is always in your best interest every year.
Right, because I mean, people don't realize that, maybe your doctor's been dropped from your Medicare Advantage plan or your drug has been dropped from your Part D plan. So, I mean, even if your premium doesn't change that much, your coverage might be changing a lot, right?
Exactly. And you don't want to find that out when you go to the pharmacy in January to fill your prescription and then you're locked into your Part D plan for all of 2026. It's definitely better to know all those details at this right now during open enrollment.
Now, there are some coverage changes, right, that people are starting to feel from really a couple of years ago, yes?
There are. So there's some basic changes, like, for example, the maximum out-of-pocket cost on Part D plans, which just went into effect in 2025 under the Inflation Reduction Act. It was a $2,000 cap on out-of-pocket costs for Part D. That is indexed for inflation. So for 2026, it goes up to $2,100. So not a huge change, but definitely a change people should know about. And you do still have the option to work with your plan to spread that out in equal payments across all 12 months of the year instead of having to meet it right at the beginning of the year if you take an expensive medication. There's a change in the maximum Part D deductible, just like there is every year. This year, it's for 2025, it's $590 is the maximum deductible. It'll be $615 next year. That doesn't mean your plan will have a $615 deductible, but it might. But there are also plan-specific changes that vary from one plan to another. So, for example, your Medicare Advantage plan might be adding or subtracting supplemental benefits. They might be changing the amount of your deductible or changing the amount of your inpatient hospital copay. There's all sorts of changes that aren't necessarily broadly applicable, but that apply to your plan. And then, like you were saying, whether or not your doctor and hospital are still in the network, whether your prescription drug is still covered at the same level. Plans can move prescription drugs from one tier to another. So those are all the sorts of things you really need to pay attention to now so that you can comparison shop and see if something else might be a better option.
And we are seeing plans starting to sort of drop out. I mean, I know at one point there was concern that there were too many plans for people to choose from, that it was too confusing. But now are we running the risk of having too few plans in some places?
Well, I think the concern about too many plans is definitely valid. For a while, it could definitely be overwhelming for people shopping for coverage. For both Medicare Advantage and Part D, we do have overall an average of a reduction in how many plans are available. For next year, there are a few states where the average beneficiary will actually see more options for Medicare Advantage, but that's rare. But the average beneficiary will have access to more Medicare Advantage plans than they did before 2022. For example, it's just been in the last few years that it has decreased, but it still hasn't decreased below the level that it was in 2022. So it's still a lot. I believe it's an average of 32 plans. And then in the Part D, for people who buy standalone Part D coverage, everybody has between 8 and 12 plans to pick from. So if your plan is ending, you obviously need to shop for new coverage. If you're on a Medicare Advantage plan and you don't shop for new coverage, you'll just be automatically moved to original Medicare on January 1st. If you're on a Medicare Advantage plan that's ending because your carrier is exiting the market or pulling out of your area and your plan can't be renewed, you can pick any other Medicare Advantage plan that's available in your area. But you also can switch to original Medicare and you'll have guaranteed issue access to Medigap, which is not normally the case. During this open enrollment period, people have guaranteed issue access to Medicare Advantage and Part D, but not Medigap. So for other folks whose Medicare Advantage plan is continuing, obviously they have the option to switch to original Medicare, but depending on how long they've been on their Advantage plan and what state they're in, they do not have guaranteed issue access to Medigap. So that is an important thing for folks to know if their plan is actually ending, is that they can make that choice if they want to.
We've seen a lot of increases in healthcare costs overall, and I guess that's true for Medicare too. I mean, why should people who aren't on Medicare care about what happens to Medicare and what happens to the Medicare market?
First of all, hopefully all of us will eventually be on Medicare. Almost everyone by the time they're 65 is on Medicare. But even if you're a long ways away from that, it is important to know how much the whole Medicare sphere in terms of the insurance companies and the regulations, how that sort of trickles down to the rest of the commercial insurance sector. Drug price negotiation, for example, that will have a trickle-down effect into what the insurance companies, in the rest of the commercial market pay for drugs. When regulations come out for Medicare, the insurance companies follow suit in the private market, or states will follow suit in terms of how they regulate the private market. So it certainly does matter for everyone, even if it's not a direct effect.
So even if you're not 65 or helping somebody who's over 65.
Exactly. Yes. And that's the other thing, is a lot of folks who are younger are helping a parent or a grandparent navigate this. And so it's, it really does affect most people.
Yeah, it is. It is one of the autumn tasks for many people.
Absolutely.
Helping mom and dad or grandma and grandpa navigate their Medicare coverage for the following year.
And I do think, like you were saying earlier, as far as letting it ride, obviously if you comparison shop and you're happy with your coverage and you've determined that it is still the best option, then yes, you do not need to do anything. You just, assuming it's still available for renewal, you just let it renew. But oftentimes I think people don't comparison shop simply because the process seems overwhelming and they just figure, I'll just keep what I have. And of course, if you're in that situation, you might be one of the people who's on a Part D plan that's increasing by $50 a month next year, or you might find out in January that your doctor's no longer in network with your Advantage plan. So if you get those notices from your plan and something doesn't make sense or you're confused, it's much better to reach out to someone who can help you, whether it's a family member or friend, asking them for help, or call 1-800-MEDICARE, call the Medicare SHIP in your state. Every state has a state health insurance assistance program that's staffed with people who can answer your questions. Contact a Medicare broker in your area. Just asking questions and finding out the answers is a much better approach than just assuming things will work out if you just let your plan renew.
I'll put a link to your site also.
Oh, yeah, MedicareResources.org. We do have an open enrollment guide where we list all of the changes that are happening for 2026, the broad changes. And we'll continue to update that. Like, for example, we don't yet have the Medicare Part B premiums for 2026. So as those numbers come out, we'll update that guide with everything people need to know.
Louise Norris, thank you so much.
Absolutely. Thank you so much for having me, Julie.
Okay, we're back. It's time for our extra credit segment. That's where we each recognize a story we read this week we think you should read too. Don't worry if you miss it. We will put the links in our show notes on your phone or other mobile device. Joanne, why don't you go first this week?
The piece I have this week is from Mother Jones, and it's about Florida Surgeon General Dr. Joseph Ladapo. And the headline is From Medicine to Mysticism, the Radicalization of Florida's Top Doctor by Kira Butler and Julianne McShane. It's a phenomenal read. He has stellar credentials, Harvard, Stanford. He was a academic medicine, MPH, he's public health and medicine. He had this stellar traditional career. He was widely respected. And now he is like this leading voice. He's trying to get rid of the vaccine mandates, childhood vaccine mandates in the whole state of Florida. He has questions all sorts of established public health practices. He is out there. And we've sort of all wondered, how do people get to this point? And this story talks about his wife and her mysticism and their guru healer who walks on their thighs to the point that it's painful. And they emerge from this foot walking, thigh walking thing and his mystical experiences with this whole different take on the human experience and the role of health. I cannot begin to capture it. And here it is a long, detailed, and fascinating read on his wife who he met on an airplane and her beliefs in we bring certain things on ourselves because of who we are and who are the ancestors that we carry. She sees auras and visions, and this is their current belief system, and it is not compatible with what most of us think of as science-based public health. Really good read. Really, really good read.
Definitely Maha to the max. Anna.
Mine was a guest essay in the New York Times, the drug that took away more than her appetite. And I thought it was a really great look at how some of these obesity medications, the GLP-1s, like Ozempic and others, can be used to treat addiction. And so that it follows this woman who was addicted to different kind of drugs at different times, and she lost her children and all sorts of horrible things, and had tried over and over again to stop using, and then has been in this program that uses a version of these GLP-1s at a lower level. They don't necessarily want you also losing weight, but to treat addiction, and just how it's kind of been the only thing that's worked for her. It stops the cravings, kind of as you think it might do for people with obesity as well. I thought we don't see this as much, and the companies that make these drugs are extremely focused on this. So I thought the article did a good job of saying why this could be really important, and looking at the fact that right now it requires federal funding of research to keep the promise alive, and hope that at some point some pharmaceutical company will be more willing to pick it up.
Yeah, right now there's a lot more money to be made in the obesity side of this. But yeah, it's a really interesting story. Lauren.
I actually highlighted work from Rachna Pradhan and Samantha Liss from KFF Health News. The article's titled "Senators Press Deloitte, Other Contractors on Errors in Medicaid Eligibility Systems." Its impact from their great reporting, which I think we talked about on this podcast earlier in the year, about talk about waste, fraud, and abuse, that there's some questionable issues with how Deloitte manages Medicaid systems and how money's being wasted through them. And the senators, it looks like, read KFF Health News' reporting and have sent some letters about it. So great work by the team over there, and eye-opening for sure to see on some of the dollars Medicaid that are not going to patients.
Journalism impact. My extra credit this week is a really thoughtful story from our fellow podcast panelist, Alice Miranda Olstein at Politico. It's called RFK Jr.'s Got Advice for Pregnant Women. There's limited data to support it. It's about a topic that I have been covering for more than 3 decades, the difficulties of including women, particularly women of childbearing age, in clinical trials of drugs. As Alice outlined so well, the problem isn't just ethical. An unborn fetus obviously can't give informed consent to be part of an experiment, but it's also a question of liability. Drug makers are afraid of getting sued for bad pregnancy outcomes, and with good reason. That's why it's so hard to know what is and isn't safe to take during pregnancy, and what might cause birth defects or miscarriages. And despite the secretary's promise to, quote, do the science, it is not that easy. It's a really, really good read. Okay, that is this week's show. Thanks this week to our editor, Emery Hudeman, and our producer-engineer, Francis Yang. If you enjoy the podcast, you can subscribe wherever you get your podcasts. We'd appreciate it if you left us a review. That helps other people find us, too. Also, as always, you can email us your comments or questions, or at whatthehealth, all one word, at kff.org. Or you can find me still on X at jrovner, or on Blue Sky at Julie Rovner. Where are you folks these days? Joanne?
I'm either on Blue Sky at Joanne Kenen or on LinkedIn.
Anna?
Blue Sky or X at Anna Edney.
Lauren?
I'm on X or Blue Sky at Lauren Weber HP.
We will be back in your feed next week. Until then, be healthy.